So welcome to tonight's webinar, which is on a topic we have never covered before. We've put such a focus on the medical needs of children with Marfan, LGS, and VEDS, justifiably so. But we know that for our kids, it's about much more than their physical health. We need to pay attention to their mental health, their behavioral health, their learning capabilities. And this is a challenge because a lot of these are issues in the general population. So is it their connective tissue condition that's causing it? Is it a coincidence? Is it bad luck? I think we're going to hear a lot about that tonight. What's observed at a clinic that sees a lot of kids with Marfan and related conditions. There are true experts in the field from Stanford, which has been an incredible partner to the foundation for decades, really, with one of the leading Marfan and genetic conditions clinics in the country on both the adult side and on the kid side. And I remember one of my first annual conferences with the foundation was out at Stanford in 1997. So you guys have been setting the bar for us for a really long time. So before we get to our speakers tonight, I want to introduce our president and CEO, Michael Weimer, to say a couple of words.
Thanks, Eileen. Good evening, everyone. Reflecting back on Stanford, we were there a couple of years ago for the annual conference, at least like it seems a couple of years ago. And I remember the hottest program that weekend was the swimming pool. I think it was jam-packed every evening, and it was a wonderful opportunity for kids and families to spend time together. Very warm memories of that. Good evening again. It's great to have so many people joining this tonight. It has more registrations than a lot of our programs have had. And I think that's a sign of the importance of this topic tonight. And we're honored to have our friends from Stanford here. It's a busy time at the foundation. About a week ago, we released our new website, marfan.org. You can go to and new look, lots of additional information. Loeys-Dietz, vascular EDS, Stickler, the GenTAC Alliance, which is the science arm of the foundation, are all included on that new website in a different way than previously, which is great. We're going to be actually out in California this summer. If you're not familiar with our annual conference, we will be at Hogue, which is in Newport Beach. And it's July, I think, 8 through 10, first in-person live conference in 3 years. Seems like more than that, but in 3 years. So we really are looking forward to a really large turnout, and we will have a terrific program working with our friends out there. We also have a brand new updated research program. For the first time, we're offering an Everest Award, which will be the largest award in the history of the foundation. It will be an $800,000 award, $200,000 per year over 4 years. We've done an exciting update of our research program. And then we have lots of additional activities this month. I'm sure that Eileen will be talking about. We have another COVID-19 update. They have all been extraordinarily well attended, always changing information. We're also starting some Loeys-Dietz chats. We have a very active VEDS community, if by chance you have vascular EDS. So anyhow, lots of great things going on. Not hard to find us ever. With that, I'd like to again thank our guests this evening. And Eileen, I'll kick it back to you.
Great, thanks so much. So before we get to our speakers, I just want to thank everybody who has pre-submitted questions. We're going to get to as many of them as we can. I did send them ahead to the speakers tonight, so I'm sure you'll get a lot of your questions answered during the presentation. If you have questions afterwards, put them in the chat, not in the chat box, in the Q&A box. That's where we'll be taking questions from later. And if you can just kind of stick to the topic at hand, because we're going to skip over questions that are not answerable by these particular panelists. So if you have medical questions that you pre-submitted or are not related to the topic, we'll post the Help Center email later tonight, and you could submit them there. So now it gives me great pleasure to introduce Dr. Tom Collins, who is the Clinical Associate Professor in Pediatrics and Internal Medicine at Stanford University School of Medicine and Director of the Cardiovascular Connective Tissue Disorders Program at Lucile Packard Children's Hospital at Stanford. He will introduce our other speakers from this institution. So.
Thanks, Eileen. Thanks for the opportunity for us as a team to present. We're really honored to do this and excited to be a part of what's going on with the Marfan Foundation. So I've got a couple of colleagues that are going to be speaking this evening to everyone. I call them colleagues. I would also call them friends, I think, at least from my vantage point. And so those two are Mark Beidelman. He's our neuropsychologist that works in our program and sees all of our patients. And then Alan Reese is our psychiatrist. And Mark, just as a little bit of background, Mark has a doctorate in psychology. He got that from California School of Professional Psychology at Alliant International University in San Francisco. And then Dr. Reese is about as distinguished a person as I've ever met in the field of medicine. And in fact, has his own Wikipedia page. So that probably says something.
I didn't make it. Someone made it for me.
I would say that I hold these two in high regard, and I could not show a higher example of that. And then they've both helped my wife and I with my son. So they've cared for him too. So anyway, without further ado, I'll open that up for them so that they can begin talking.
Okay, I think I'm first up. I'm going to go ahead and share my screen. Okay, so it's a pleasure to be here and be able to talk to the folks who have registered for this webinar about what the current state of the knowledge is with respect to behavioral health, broadly defined in these connective tissue disorders. This is an important slide. You should always pay attention to this in terms of disclosures. Is anyone receiving funding from this or that? And the answer for me is no, I don't have any financial disclosures to tell you about. So that's easy. Let's move on. So I'm going to give you a little bit of a background in terms of some of the concepts that I think are going to be important for us to talk about and think about in this webinar. And Mark and I are going to try and leave a good amount of time at the end, by the way, for Q&A. So this will go, I think, pretty fast. So, you know, there's the age-old question, are human beings more affected by nature or nurture? And when it comes to mental traits, behaviors, learning, and so forth, it gets, you know, that debate can get particularly heated. But the truth is, it's not either. It's always and. It's always both. So you always have biology and environment affecting outcome, and even more so, the two work together to affect outcome. Okay, so along those lines, let's talk about some important concepts about genes, environment, and what we call G by E, or that's genes by environment interaction. Number one, your genetic background is never deterministic. So you never go from A to B based on a specific gene or a gene pattern that you have. Even in very, very severe diseases, inborn errors of metabolism and so forth, there's a lot of variability, and that seems to be at least partially determined by the environment and interaction with the genetic background. So you got to think about risk whenever you have a particular genetic variable or genetic trait. You have to think about, well, okay, does this confer a particular risk for a particular outcome, or sometimes does it confer protection? When it comes to complex neuropsychiatric syndromes or cognitive function or disorder, so ADHD, learning disorder, schizophrenia, or autism, it's extremely challenging to identify specific genetic contributions. So keep that in mind. We're making a little progress in that area in the field broadly defined, but it's still very, very challenging. Another concept that's important is that environment begins at conception. So most people think about environment as being operative once a baby is born, and it has to do with the household and so forth, but all those prenatal effects actually contribute to environmental effects and interaction with genetic effects. The effects of environmental factors depend often on the developmental windows in which they occur. So a particular environmental adverse effect may have very little contribution to outcome in one particular period and a very large contribution in another. And the same with positive environmental effects. Gene-environment interaction occurs for all human traits. And saying something is heritable or genetic does not mean that all the different causes are the same that lead to that outcome, or that they're even mechanistically similar. What we found now in psychiatric and cognitive disorders is that multiple different contributions can seem to arrive at the same phenotype or outcome. So it's a very complex issue, and hopefully we're step by step unraveling that over time. Okay, some of you may have heard about DSM disorders or ICD-10, DSM-5 disorders. This is a diagnostic and statistical manual. This is what people in the field use to make diagnoses in psychiatry and psychology. And so what does it mean to have a diagnosis of attention deficit hyperactivity disorder or autism spectrum disorder or an anxiety disorder, depression, schizophrenia, et cetera, et cetera? Well, this is what it means. You have that diagnosis here, and there are multiple pathways that can be traversed to arrive at that diagnosis. And what's even more is you have more risk factors, some of them operating more signally because they have large effects. Some require combinations of risk factors to start a neural pathway that could lead to a diagnosis. So this is what I'm talking about in terms of complexity. So when people talk about ADHD and autism spectrum disorder, depression, and so forth, think about it in this way. Don't think about it like having pneumonia due to a particular bacteria. It's not that. Let's get to it now in terms of connective tissue disorders. So is there a genetic risk for brain effects in Marfan syndrome? So for learning disorders, and many of our questions that came before this webinar, we're asking basically this: does the mutation in Marfan syndrome increase risk for brain effects that lead to cognitive and psychological psychiatric problems? Well, we know that the genetic mutation that leads to nearly all cases of Marfan syndrome in the FBN1 gene. It alters fibrillin, and there are if you look at the scientific literature, if you do a database search, you can find a lot of papers that report associations of FBN1 mutations, Marfan syndrome, with schizophrenia, anxiety, depression, autism spectrum disorder, ADHD, learning disorder, sleep apnea, multiple sclerosis. I don't have that in my list here. But the truth is almost all of these, in fact, I think all of them are case reports or case series. And there, I can tell you a joke if we have time at the end about case series and case reports. But the truth is, there is no definitive study that shows one way or the other. I'm not discounting that there's a possible association, but one way or the other that there is an association. Now, why might one think that there could be an association between mutations of this particular gene and effects on brain development and function? Well, fibrillin-1 functions as what we call an attachment protein in the basement membrane that provides structural support to the blood-brain barrier. And the blood-brain barrier is this really important component that protects the brain from various substances in prenatal and postnatal environments. And so is there a possibility that mutations could affect the blood-brain barrier, making the brain more vulnerable to certain types of insults or effects? Maybe. I don't think anyone has shown that in any way definitively. You also have to consider vascular issues in children, teens, or adults with Marfan syndrome, for example, from tortuosity. Finally, there can be variability, as many of you know, in the clinical manifestations of Marfan syndrome that reflect, number one, variants of the mutation in FBN1, as well as potential interaction with other modifier genes. And this is not a new concept. So genes rarely, if ever, act on their own. They interact with families of genes, other genes that can affect outcomes in people who have mutations of the primary gene. So does Marfan syndrome increase risk for neuropsychiatric or learning disorders? I don't know. I have absolutely no definitive idea at this point, but we can answer this question with a well-designed research study. And we've been talking about this at Stanford, about how we could potentially start one of these studies and maybe even have it be multi-site, using multi-dimensional assessment instruments and appropriate comparison groups. And I'll tell you what I mean by that. So what would we really, in the ideal study, look at to try and answer this question? We would look at psychosocial and behavioral characteristics. We would look at cognitive and neuropsychological abilities. We would look at that type of variation that I was just talking about in the FBN1 gene and possibly its interaction with other genes. We would look at brain imaging. You might say, well, why would we do brain imaging? Well, imaging of brain structure, function, connectivity, metabolic aspects will give you important information that's much closer to genetic structure than, for example, measuring behavior and cognition and learning. We'd also have to measure specific environmental moderators, so the socioeconomic status, aspects of the family, how good a fit is the school that a child is going to if it's in pediatric population. Medical morbidity, I'm going to talk about this more later. You know, how sick is this child? How many operations has he or she had? Quality of life, and then of course medication effects. And you know, there's lots of casual, generally casual information about possible effects of medication on mood and learning. And certainly it doesn't take a scientist to figure out, you know, if you're taking a medicine that makes you sleepy and fatigued and drowsy, that's going to affect your behavior and your learning. What do I mean by appropriate comparison groups? Well, if you just compared children and adolescents, for example, with Marfan syndrome to what we call neurotypical controls, or typically developing children that don't have Marfan syndrome, you have all of the overlay of issues related to the medical morbidity. And so those by themselves can certainly cause increased stress, interference with learning, psychosocial, behavioral issues. And so it's not an appropriate control group. And we've been thinking a lot about this, because you do want to have an appropriate control group, at least one control group that has medical features without the same specific genetic risk. Well, what about in VEDS and LDS? You know, of course, this is a condition. These conditions are much less prevalent than Marfan's. I think it's probably 25 to 50% less, if I've read my epidemiology literature correctly. There is a paper from a very famous author a couple, 3 years ago, parents reporting problems with motor and speech development and feeding in children with vascular EDS. And of course, that was Tom Collins, who's also on our webinar today. So yeah, there is a hint of this. And certainly in our patients, we've seen evidence of that as well. Do I see as much evidence in vascular EDS as I do in Marfan syndrome? No, I don't, at least in our populations. When we do see it, at least in my view, what I find it's related to fatigue, hypotonia, maybe other motor issues and so forth. Now, would we believe that there's some possibility that vascular EDS should have a role in brain development and function? Well, collagens are a major constituent of the membrane covering of the brain, which plays an important role in brain development. So conceptually, theoretically, there could be something there. And for both conditions, variants and modifier genes also might affect clinical severity. And of course, you cannot put aside issues related to arterial malformations, aneurysms, dissection, hemorrhage, tortuosity in the brain that could also affect, certainly later in life for sure, but perhaps even early in life. Okay, so I promised we would get to this, medical associated stressors. This is a big issue, as you folks know, in our population. There's loss of visual acuity, restriction from desired activities due to fatigue, pain, orthopedic problems, and medical guidance, medical restrictions. So can't exercise. We just spoke with a teen and his family who was, I wouldn't say devastated, but very, very unhappy about this. Restriction from being able to hang out with his friends, playing sports. This is a big issue for him. And it caused a fair amount of anxiety and depression. Worry, concern over physical appearance. Am I going to be accepted? Am I going to be rejected by my peers based on my size, based on the way my face looks? There are, as you know, unpredictable and potentially life-threatening events that can occur, or anticipating life-threatening events. We've seen many individuals, teens in particular, who've talked about the stress that this causes for them. And then even, you know, if you're not expecting a life-threatening event, you have to have surgery in many circumstances. And that by itself is a significant, remarkable stressor. And there was an interesting article that I found, was not aware of it. It was in BMC Psychiatry on the effects of acute and elective cardiac surgery on anxiety in patients with Marfan syndrome, and found that if you involve psychiatric mental health care at the beginning, in addition to surgical treatment interventions, you have much more successful recovery and less anxiety of patients with Marfan syndrome. So that's one takeaway I wanted you to know about. If that wasn't enough, we of course have the pandemic with everything else. I'm hoping, of course, like everyone else, that we're emerging from this really, really tough year and 7-8 months now over the next few months. But of course, if the pandemic has taught us anything, it's that we can't predict what's going to happen. There are stressors related to health risks or actual health challenges throughout the entire family. Sheltering associated stresses. I've had families tell me they're going nuts having to stay at home and supervise their kids much more than they used to. Economic pressures from layoffs or furloughs, even changes from the usual routine, reduced activity level, not being able to go out and do the things you normally do, separation from friends and extended family, separation from work, and increased medical problems because you don't have as much access. These are all relevant issues. The potential mental health issues of both the primary connective tissue disorder as well as pandemic that we see commonly in our patients include anxiety, depression, increased behavioral problems that can be as something to the extent of not listening, being more irritable, or even significantly more problems with anger, for example. Fall off in self-care skills. He or she's not bathing themselves as often. They have increased sleep problems, fall off in school performance. These are all common issues and problems that we're seeing in our population, or we have seen, that I think is also pandemic enhanced. By the way, I will tell you as a child and adolescent psychiatrist, as well as clinical neuroscientist, that at least in the United States, there is now close to a emergency declaration based on pandemic-related increase in suicidal thoughts, feelings, and behavior on the part of children and teens here in this country. And it's really become quite bad over the last 18 months. All right, so what can you do? This is just kind of an outline. And again, in the Q&A, we will get into more details. Well, first of all, one size never fits all. You have to, for an individual child, for an individual teen or young adult, you have to identify the individual profile of risk and resilience. What are the strengths of that human being? And then what are the challenges that they have? Where do they tend to fall off the horse? On the part of parents, consistent positive reassurance and role modeling. So how do you deal with anxiety? Kids are going to look to parents. And in fact, most of the current most effective anxiety treatments for children now involve the entire family, particularly the parents in terms of this role modeling component. Particularly in the pandemic, daily schedules, of activities can go out the door. So creating a daily activity schedule where one was not before can be anxiety reducing. Activity, exercise certainly is tolerated, recommended by our medical professionals, can really be quite anxiety reducing as well. And I'm not making that up or saying that as kind of what I think. It's actually, there's scientific data that show that activity doesn't have to be rigorous exercise. Increasing activity improves your sense of well-being, reduces anxiety, and can have an effect of certainly reducing depressive symptoms if they're mild. Taking advantage of opportunities for positive social interaction, that's really important as well. Again, and during the pandemic, I think there's much more tendency to get isolated and to just drop into that zone of being isolated. So taking the opportunities not only on Zoom, but outdoors, masked indoors for positive social interaction. And then, of course, with respect to sleep, reducing activities that interfere with sleep. This oftentimes is a big tug of war, particularly between teens and parents in terms of screen time. But I tell our teens, I say, look, here's the science. Screen time before you go to sleep will interfere with your sleep onset, will interfere with your sleep maintenance. Some other approaches. So that first set of approaches was more, what can you do at home? Well, how about professionally? In general, the two types of therapy that we think are most effective for these types of problems that we're talking about, particularly anxiety and depression, are cognitive behavioral therapy and sometimes family therapy, and sometimes a combination of the two. Medication, usually not first line, but certainly if you're dealing with a person who has significant attentional problems, sometimes we will recommend medication for that. Or anxiety in particular that's not responding to therapy, we will use anti-anxiety medications as well. And certainly for depression that's not responding to therapy. And school-based interventions, I'm going to let Mark talk about in his segment, but those are oftentimes very effective. Your kid spends a lot of time at school. So if you can have an appropriate curriculum and accommodations, it can do a lot to ameliorate problems with behavior and psychosocial issues at school. So last two slides. I would say when you're thinking about intervention in particular, don't get discouraged if the first thing that you try is not working, because sometimes it just doesn't work and it's not a good fit and you need to move on to other possibilities. So if you're engaging a mental health professional with respect to treating your family member with a connective tissue disorder, ask about their capabilities, what sorts of treatments they provide, what do they do if a particular treatment does not work. And the same is true for research, by the way. Research is oftentimes what we call iterative, so you build on previous knowledge to try and expand scientific awareness and knowledge. And with that, I will leave you to live long and prosper.
All right. Let's see. And we can all see this, yeah?
Yes.
All right. So I'm Mark Beitelman, as we kind of mentioned before. Just a quick little thing about my background, because I will be probably talking about this a little bit through this talk, and I want to be mindful of the time, just so we do leave some time for questions. So I might speed through some of this. My background is actually quite mixed amongst pediatrics and adults, including, for a long time, my focus was with veterans and working on PTSD, neuropsych testing in the veteran population, and even a lot of neurodegenerative disease work. It's been the last, 10 years or so, I've been working within the pediatric neuropsychology population. And a lot of my work, probably 70, 80% of it, is here in various aspects of cardiac or congenital heart disease programs, with also some just kind of general developmental behavioral pediatric stuff. So kind of piggybacking off what Alan was saying. Let's see, I'm not able to advance. There we go. Just Monday, the psychologist Aaron Beck passed away at the age of 100. He was one of the two founders of what is sometimes referred to as CBT, or cognitive behavioral therapy, really the foundation for evidence-based modern psychotherapy. Now, there's lots of tree branches that have evolved from there. CBT is still widely used, and you know, I often joke it's kind of our evidence-based snake oil, where it kind of cures what ails you. You know, it's like, if you got schizophrenia, if you got anxiety, if you got depression, you want to quit smoking, here's some CBT, and it does work pretty darn well. But what influenced Aaron Beck and his colleague Albert Ellis were the Stoic philosophers, and I'm a big fan of the Stoic philosophers, and I think kind of talking about what Alan was talking about, both in the context of DSM disorders, but also in kind of this resiliency kind of way. I think something to keep in mind for me is mental health versus mental illness. And I don't really like a distinction between the two. I really kind of think of it as, yeah, whatever kind of risk factors or situations we have might predispose us to kind of one of these categories. But really, for all of us, it's about doing the work throughout our life. And that's kind of a big, you know, thing that the Stoics kind of talked about. Now, just to be quickly clear, the Stoic philosophers, capital S Stoic, were not button your lip, express no emotion people. They were actually quite emotive. But what they really kind of emphasized at the core of what they talked about is it's how you relate to the world that dictates your inner experience. So just a few quotes from four of the big guys of the Stoic world. Marcus Aurelius, probably the most famous. The world is nothing but change. Our life is only perception. Really like that one. People are not disturbed by things, but the views they take of them. That's Epictetus. He was born a slave. As long as you live, keep learning how to live. Seneca. Again, kind of saying that all this psychology stuff is going to be an ongoing process. And Zeno, kind of the founder of all this thought, well-being is attained little by little, and nevertheless, it is no little thing itself. Again, kind of that ongoing process mentality. Now, really kind of what do I do and what is neuropsychology? I suspect if you ask my family and a lot of my friends, they really wouldn't have an idea of what I do for a job. They probably would say something with veterans, or I don't remember, you know. But we'll quickly kind of go through what is kind of neuropsychology and kind of how does that relate to some of the things we'll talk about here. Real basically, neuropsychology is a study of brain behavior relationships in individuals with known or suspected brain injury, neurodevelopmental disorders, learning disorders, or other congenital disorders. Kind of a subspecialty within psychology. The real goal of neuropsychology is kind of figuring out functioning, strengths, weaknesses, and devising treatment planning. Diagnosis often comes along with this, both for insurance and billing purposes, but also sometimes that does kind of help communicate what's going on. But really, I think certainly in our program, and I think just in general, it's really important to really focus on where the level of functioning, again, not getting into this dichotomy of like, are you okay or not okay? It's really kind of more nuanced than that. Yeah, so and as far as the actual process goes, the tests are specifically designed to measure cognitive function or associated with a particular brain structure or kind of neural system within the brain. In its more aggressive form, I mean, this kind of testing started before we had imaging techniques, and to some degree is almost as reliable as imaging. We tailor our neuropsych batteries here to answer specific referral questions, focusing on cognition, behavior, and what are the functional capacities. So yeah, just real quickly, kind of going through the domains of what is assessed in general in any ideally in any neuropsych function. It won't necessarily be all these things. It could be, but again, you kind of want to attach it to what's going on in the individual's life. So usually almost always on a basis of intellectual functioning, IQ, cognition, whatever you want to say. If academics are of concern, language, memory, visual spatial skills, attention, executive functions, which are really a broad, lots of different skills or functioning are kind of thrown into this bucket. Organization, planning, inhibition, flexibility. The one definition I really like when thinking about executive function is it's using two cognitive skills in concert to solve one problem. I think it's a broad definition of what it is, but it does a better job in some of these little nuanced bits. Fine motor control, potentially gross motor, but we usually leave that to the physical therapist. Of course, I wouldn't be a psychologist of any variety if it wasn't going to be looking at behavioral, emotional functioning, social skills. Now, process of, if you're not familiar, and you're curious about neuropsych functioning or neuropsych testing, we'll just go through this real quick. Process typically goes, we get a clinical interview in the pediatric population with a parent. In adults, it might be something more like a coworker, parent, or it still could be a parent, spouse, roommate, you name it, friend. And really what we want is detailed developmental, behavioral, social history, medical history, kind of making sure we understand the whole picture. And that can actually really help us cater to what kind of tests we might select. Ideally, I'm using parents here, but whatever that other source of information is, they'll complete some questionnaires for us that are validated to kind of hone in where we really want to go. Also, other sources of information, teachers, a coach, a speech therapist, just to get multiple settings of how that person's functioning, to get an idea if it's situational, if it's relational, whatever. So results. What do the results tell? I think I kind of got to this already, but evaluations are going to be aimed at providing comprehensive understanding of where the person's functioning. Also, really kind of answering that question. I think an important thing that I really like to talk to people about when I am kind of meeting them and about to do neuropsych testing is really, I don't care about the scores. I probably shouldn't say that as a neuropsychologist, but I look at the scores, I report the scores, they can be quite informative, but really for me, there's the process of how somebody obtains those scores or doesn't obtain those scores is far more important than how well or poorly they may do. Now, this actually comes from a school of thought within neuropsychology called the Boston process approach, which was started by Edith Kaplan, who's a neuropsychologist. She had, and she really kind of took it from a very data-driven specialty to one that had much more of a mixture of process and data. And I'll give a couple quick examples of that. So this is a fairly common task that both kids and adults would get in a neuropsych test. We give them blocks like this that are either, there's no white ones here in this example, but they'll either be white on one side, all red on one side, or half red, half white. Then we show them a picture like on the right there, and we'll have them construct that, we time them, and that's going to give us an idea of, to some degree, motor functioning, but more importantly, visual spatial functioning. Now, how somebody approaches this can matter a lot. I mean, there's endless ways that this changes. People with neglect via strokes will approach things in particular ways. Certain conditions across the lifespan will also show at times unique approaches to this. And I think one of the things, getting back to that process versus score idea, is this is actually, it's maybe not a verbatim quote, but a quote from Edith Kaplan talking about the process approach in one of her early papers. And she basically said, you have this 9-block design here. You have somebody who constructs this entire 9-block design correct, with the exception of one of these blocks is rotated. So 8 of the blocks are right. One of them is rotated a quarter turn by accident. They get a 0. You also have somebody that puts 3 of the blocks in their mouth, throws 3 of the blocks across the room. They also get a 0. So if you're just looking at the score, you're not getting a whole lot of information. Likewise, there's visual spatial construction task. This is from a study looking at kids with and without ADHD on clock drawing. And I mean, the drawings themselves are pretty, I think, self-explanatory of the poor motor planning and potentially impulsivity of the child with ADHD versus the non-ADHD's child's clock looks reasonable. But there's a lot more info in there, right? So we don't know if that's motor planning, if that was an executive function skill, kind of more related to impulsivity or inhibition. And there's a whole lot more without giving the test away in case any of you all wind up in a neuropsychologist's office. I don't want to spoil too much of this, but there's a lot of other things we look at as part of even something as simple as drawing a clock. Now, of course, these are two kind of visual, spatial, executive, motor tasks that I'm using for these process approach. But it's true of even things like if we ask people to define words and we prompt them for more, how do they process that prompt, or how do they kind of work at getting towards a better answer with that kind of prompting? There's all kinds of different ways this plays out, and I could probably talk for a day about that kind of stuff. So more to the point of why we're here. As I said, I work not just in the connective tissue disorders clinic here, but also amongst the few cardiac populations. And this is kind of an important takeaway that I think, again, if I meet somebody, they say, oh, what do you do? Oh, I'm a psychologist at Stanford. I mostly work in cardiology. Why are you in cardiology? That's always the first question. And I think it's important to remember a few things here. So one, throughout the lifespan, cardiac dysfunction will really impact brain structure and functioning. And that's true of certainly of congenital heart disease. And there's even within some of the populations I see, like the single ventricle population, very specific ways that often shakes out. But as Alan pointed out, it's not deterministic. There's still a great deal of variability. But even aging, the untreated, the two highest risk factors for dementia are not genetics, not bad luck. It's high blood pressure followed by high cholesterol. And so it's really important to kind of take into account how important the heart really is for our brain functioning. They also develop step in step. So congenital heart issues may also have congenital brain issues. And there, again, that's a different topic for a different day. But I also think it's important to remember, even if we don't have a cardiac condition, the brain is greedy. It is a greedy jerk. It takes out about 2% of someone's total body weight, but consumes 20% of the oxygen, glucose, and blood supply. And I mean, you've probably experienced this if you've ever been kind of hard at work and maybe not eating, or you've just had a big lunch, you get hard at work at something, you're really kind of straining your brain a little bit, and you're like, there's no way I could be hungry again. I just ate. But sure enough, you can get hungry quite quick from something as simple as thinking deeply. Now, as also Alan kind of talked about, there's very, very little in the way of studies on a group level looking at Marfan syndrome. And so there's one certain good one from 1988. This is Hoffman. And basically what they found is children with Marfan syndrome, school-age children. I think the actual age range was 5 to 13, although that says 12 to 3.4. I'd have to double check that. But overall IQ was normal, if not a little bit above. So normal is 100, and that's giving us a range of essentially 95 to pretty close to 120. But despite everyone having a normal or above normal IQ, 50% had at least one or more neuropsychological deficits. And these were learning disabilities, ADHD, neuromaturational immaturity, which this study defined as kind of, I think it would be easiest to call what we call developmental delay. This is again, 1988. But also really interestingly, splits between visual spatial IQ and verbal IQ. And that was a significant split of greater than 20 points. And that was found in 30% of these kids they evaluated, and meaning the verbal was higher consistently in this 30%, the verbal was higher than the visual spatial. What to make of that? don't totally know. Again, process would really help there. But also just thinking visual spatial is a common thing that crops up across cardiac conditions. And part of that is there's a lot of white matter or connectivity between brain areas that are required in certain visual spatial tasks. I mean, that's true of any cognitive function, but visual spatial in particular kind of takes up a lot of highway space on the connectivity path. All right, I know we're running out of time, so I'll be super quick. We can talk more about this. So as far as services and resources, school district services, something like an individual education plan or an IEP or a 504 plan, which is like an accommodation plan, can be really helpful for things like academic support, behavioral support, even finding counseling or a psychologist for stresses, anxieties, whatever, physical therapy, speech therapy, occupational therapy. The list goes on and on and on. There's something like 17 different eligibility criteria for an IEP. Learning disabilities is probably the most common by far. These same kind of services are also available community-based or via the insurance. Certainly things like psychologists or occupational, physical, speech, etc. But and just this is kind of very similar to what Ellen had already said. Beyond that, resiliency things. Even if we have somebody that's struggling with their neuropsych or academic functioning, it's important to remember the whole person. So getting involved in clubs, socialization, peer support, sports activities, hobbies. Big fan. I'm personally a big fan of art, music, etc. And certainly if those are great, psychologically great for an outlet, they're also cognitively stimulating. They produce a lot of self-esteem, and if a cardiologist is not approving your sports, that's a great one. I'll put that plug in. And that's the end of my slides.
Great, thank you so much. I'm going to ask Alan to come back here. And you guys did a great job answering a lot of those questions that were pre-submitted. So I'm going to just grab a few here. I know we don't have tons of time here, but there were some really good questions I thought we could delve into a little bit more. Oh, I should probably put myself on. It's weird that you can't see me. Okay. As I'm talking and nobody can see me, it's that voice. So can we just talk a little bit about social development, because people want to know, like, when a child's diagnosed, then they transition into adolescence, like, what have you seen in terms of the social development and psychological problems as they get older? Oh, we can't hear you, Alan. You're on mute.
I thought everyone was a lip reader on this. Sorry. Someone asked a good question on the Q&A. I think so. I'll read this. Any thoughts, comments, research on impact psychologically kids whose stature is atypical for their chronologic age and level of maturity? Maybe they're thinking subconsciously other people perceiving them as immature because their stature makes that person think that they're older than they really are, and so should have unrealistic expectations for behavior. And I've actually had this discussion with many teens, and actually younger than teens, who have Marfan syndrome. And part of it is relating to this issue of how one conceptualizes one's own identity, and what does it mean if you perceive that someone is rejecting you? Is it actually correct perception? Is someone perhaps not looking at you in a particular way? Does that really mean disapproval or rejection, or could it mean something else? And even if it does mean so-called disapproval or rejection, how can you deal with that? And what does that mean for you? Does someone's rejection actually mean that you're a person who should be rejected, who's not worthy of acceptance? And how can you deal with that, conveying that information to your peers, both at your grade level and older? So that process is an interesting one, and it partly depends on the personality of the child or adolescent who's affected. Some who are really resilient can brush it off pretty fast. Others who are pretty sensitive and already prone to anxiety or rejection sensitive need more time to go through the process of thinking that through and thinking about how they can fortify themselves. But absolutely, it's very common. and it's something that can be rectified quite effectively.
Mark, can you explain more about that visual spatial versus
Yeah.
verbal you talked about? I think people want specific examples of what you mean by visual spatial.
Yeah, and this could look a lot of different ways. It's a broad-based kind of category. The ways we test it aren't completely comprehensive as far as how this looks in real life, but navigating through space, not bumping into things at the very simplest level, especially early on in development, but it's problem solving, it's understanding relationships. I mean, this is a skill engineers, architects, designers, et cetera. It's kind of this understanding relationships and how they kind of work. You could think simply putting together a piece of furniture from IKEA takes a lot of visual spatial skills, in the sense that you have to kind of visualize where you're going with this kind of project, looking at the individual parts and kind of putting it together. Again, this can be things like constructional, this can be body and space, this can be all kinds of different things.
Great.
Following
Alan,
directions to get someplace.
okay.
You go down the street, you turn right, and then you go half a block, and it should be there on your left. For someone who has visual spatial issues, that can be really challenging.
Because normally you'd picture it in your head what you're going to be doing. So I think I have a question. I think this goes along with role modeling that you were talking about, Alan, where like a parent wants to know how best to explain Marfan syndrome to their child. The child has attention deficit or learning disabilities, and they want to know like why they look different from other people, and how can a parent best talk to their child about their condition, knowing that all this other stuff's going on, and maybe to help normalize it a bit.
Yeah, so I'll tell you how I do it, or how I advise parents, is that every single human being carries variations of their genes, every single person. Some we know about just because it leads to some sort of difference in how we learn or how we look, how we grow, and so forth. Others we don't know about because it's not so readily apparent on the outside, but we all do. And so this is a variation that we know about because it causes these changes or these differences. And it's part of human life that we all have these variations. And for you, for the kid, I would say, or I advise the parents say, we just happen to know what your genetic variation is here. And it causes you to be a little bit taller. It causes your joints to have these sorts of issues. You may have a little bit more problems with eyesight, but you know what? It's part of the human experience. So that's kind of how I couch it. And I'm not making that up. It's really true. The number of mutations that we all carry is really amazing. And it's present in all of us.
We have a couple of kids' books that help parents talk to their kids and open up the conversation. So I'll make sure we send the links out when we send out our follow-up email to everybody.
Yeah, the ADHD and learning part, Eileen, again,
Yeah,
I'm not sure. I would say, and by the way, in addition to maybe being a little taller and having problems with your eyesight, et cetera, and having to be seen by a cardiologist, you're going to have, you may be more at risk for having learning problems and attentional problems. I actually would not, I see families who have kids with lots of other genetic conditions, and that can be part of the conversation, and oftentimes is. Right now, in connective tissue disorders, I generally don't include that, and I kind of keep that separately. And if you start looking at those stats that Mark put up there, 17%, 13%, that's pretty close to the epidemiologic percentage that you see in kids at one time or another who have learning disorders or who have ADHD, irrespective of whether they have a genetic risk. So we don't know. We just, I wish we did know, because it would actually really help.
That was my next question. How did those stats compare to the general population? So
they're close.
Yeah, that's close.
Yeah.
So, so I guess my question really, and I was thinking about this as you were all talking. So I know people want to know, like, is this related? But at the end of the day, whether the child has one of these connective tissue conditions or not, you still need to deal with these other issues. in similar ways, right?
You do, but here's the exciting thing, and this is why I'm in this area, is that if there is indeed a specific risk associated with a particular condition or genetic variation, the prospect of dealing with it in a disorder specific way all of a sudden becomes open. And so again, there's some other conditions that where I work with families where we know enough about the genetic condition and all the downstream effects that in fact there are disease or condition specific treatments that have been designed and are being tested. So it's a little bit like if you have pneumonia, I was giving that example, if you go to your doctor and he or she gives you a cough suppressant and acetaminophen and says, get some rest, and you're really sick, at least I would not be very happy with that treatment. I'd say, well, what's my pneumonia from? Is it bacterial? Is it viral? Is it because I've been having wheezing? Do I need a bronchodilator? Do I need a specific antibiotic? I want to treat the cause of my pneumonia. So in the same way, I would want to treat the specific underpinnings of a learning or behavioral condition. And we're not there yet, really, in any condition, except for not for any kind of clinical neuroscience condition. But, things like sickle cell anemia now are being treated. That's not it's not a primary brain condition, but there can be brain effects. It's being treated with specific targeted genetic therapy. So that exciting time is right in front of us. So that's why I'd say it'd be worth knowing. But you're right. You got to use the tools that you have right now.
Exactly. So I'm going to ask both of you the same question, kind of end with this, and then we'll go on to some announcements. What is the most important thing to consider when raising children with Marfan or Loeys-Dietz or VEDS?
Mark, you want to go?
That's the most important thing. I don't know. I mean,
what's your advice for these parents here tonight?
First of all, as a psychologist, I hate absolutes, as I've already kind of mentioned. I live in the grays, so this is a really hard question. But
okay, so let me just preface this by saying parents don't want gray. Parents want to know black and white. So
I'm not dancing for parent now. But what I would say most important, it kind of echoes a little bit of what Alan was saying. It really, I kind of think of this as like kind of going back to, we all have our gene differences. Yeah, we all have our strengths and weaknesses. I often make this kind of statement and joke, no matter if it's a child with Marfan syndrome or whomever I'm testing, if you flip the chairs around, I wouldn't do great across all those tests. I know that, like, I'm very certain of that. So really kind of, again, it's kind of these two concepts, which I think are really one and the same, this kind of growth mindset and grit, which are essentially, they kind of are in line with those Stoic quotes, which is, it's not so much how you experience life, if things come easy, if things are hard, it's kind of how you respond to those difficulties or respond to the hardships, whether it's psychological, academic, whatever. And so kind of taking those opportunities as learning opportunities, or using your differences as strengths in any ways you can, I think is one of I'll call that the most important thing.
Alan?
So there's no prescription, Mark, that you're going to say this is what you have to do to be a
come back for part 2.
parent. And so I'm going to tell you this, not only as a child and adolescent psychiatrist, neuroscientist, but as a parent of 3 kids now who are in their 30s. And the whole concept of strengths and challenges is so super important. You want to try to do whatever you can to enhance strengths, not just take them for granted, but enhance them, because oftentimes strengths can be compensatory for the weaknesses or the challenges. And the other thing I would say is pay as much attention as you possibly can to when your kids are doing what you want them to do. So sometimes it's really hard to get this concept across. So if your kid is argumentative, they're resistant, they don't want to go to the doctor, I don't want to go to school, you try and catch them in alternative behaviors, alternative, to what you don't want to see, and pay a lot of attention to that, because parental attention is the currency of developmental growth, and try to ignore as much as possible those things that are occurring that are not very developmentally appropriate or are problems, because again, you can inadvertently pay attention to things because it attracts your attention because it's negative or attention seeking, but in the end, you're actually reinforcing the behavior that you don't want to see. So enhance the positive, enhance the strengths, develop compensatory skills, catch your kid doing what you want them to do, and pay a lot of attention to it. That's my formula.
I love that. I love that. Don't go anywhere. We're going to just have some final comments here. We did the question and answer. I just want to let everybody know, first, Mark and Alan did an amazing job of incorporating answers to all your questions that were pre-submitted, the ones that were related to this topic. If you have additional questions tonight about this topic, or you have medical questions that were not answered, you can send them to our help center. Go to marfan.org/ask. And those questions will go to Jen Lynch, who's the nurse who runs our help center. And that's really the fastest way to get those answered. So Jan is always there to help people. There's a lot of things coming up specifically for kids and teens. So I wanted to share these with you. As Michael mentioned earlier, we have another COVID update November 8th. That's Monday night, talking about boosters, vaccines for kids now in the news and available. So Dr. Kim Eagle, who reviews all the research for the American College of Cardiology, will be here and share with you and answer your questions. A really great webinar next week, Beyond the Selfie, talking about body image, where we have a professional and then 3 members of our Marfan and Loeys-Dietz community. That should be really great next Thursday night. We have monthly teen chats and teen game nights. We have a monthly kids club, which is all virtual. Again, this year, we're doing a virtual holiday party for kids. More details to come on that sometime in December. Last year, we had a magic show, and it was really, really a lot of fun. And then, of course, everybody in the community is welcome to get together at our Walks for Victory. These are really great. I mean, I remember one actually pre-pandemic, I should say, in Orlando, where one parent came up to me and said, "Oh my God, my teen met 3 other teens. They're the same age, same condition. This has never happened before." And really great opportunity for your kids and teens. The next one is in Orlando in December, but if you go to our website, they're all listed. We have lots coming up in the spring. And then just a few, I can't not mention Camp Victory, which is coming back next year on pause because of the pandemic, but we're having family camps, which are the weekend camps, and then week-long kids camps, one outside Atlanta, one in Northern California, and one in Ohio. So you'll hear more about that also. But again, trying to normalize childhood for kids in a safe environment where we have programs just for our kids with Marfan, Loeys-Dietz, and VEDS, nurse on staff, foundations, social worker on staff, and a lot of special programming for them. As you can see, this girl is climbing up this ropes course all by herself with adaptive material, and it's really empowering and builds self-esteem. And I would think that would go a long way even after they leave camp. So I want to thank our panelists tonight, and Dr. Collins, who I don't see right now, but thank you also. And thank everybody for being there. Here he is. And do any of you want to share some last thoughts? Some final thoughts? Dr. Collins, what did you think?
I thought it was great. I think this is something that is a really important topic that the 3 of us have been talking about now for quite a while, and a lot of our families have interest in this. And so I think this was spectacular.
Great. All right. Well, thank you both. Thank you all 3 of you for being here tonight and for your talks. And thank you all for joining us. And we hope to see you at another webinar in the future. Have a great night.
Thanks for having us.
Yeah.